Welcome back to the NCD Academy panel discussion series on COVID-19. It's my pleasure to be moderating this final series installment about building back better to put people first in the NCD response. On behalf of the NCD Alliance, I hope you found value and that you found useful our COVID-19 programming on NCD Academy, the course developed with our partners at the American College of Cardiology. And this course is on recommended care for people diagnosed with COVID or experiencing a chronic health condition during this time of crisis. We know that COVID-19 is, of course, a public health challenge, and the strides that we're making in our clinical understanding of the virus must be embedded within strategies and systems that protect the vulnerable, are equitable, and allow for broad access to care. That is the goal with this series, that we are looking at the implications of COVID-19 at the health systems level and the unique challenges that are being faced by systems in different regions as they face the COVID epidemic. The series is looking at how can we recover and build resilient health systems, and is hearing perspectives from recognized leaders from civil society, healthcare professionals, and people with lived experience themselves. The panel today will be focusing on systems thinking regarding COVID, and we'll be looking specifically at the challenges posed by non-communicable diseases. People living with non-communicable diseases, or NCDs, are particularly vulnerable to COVID, and the pandemic is shining a light on the need for healthy populations, strong health systems, and really noting the need for investment and a strong NCD response. So strong NCD prevention and control, with NCDs being a key piece in a building back better agenda from the COVID pandemic. My name is Christina Parsons-Perez. I'm Director of Capacity Development at the NCD Alliance, and I am joined today by a fantastic group of experts to discuss building back better within the context of high-income countries. And it is my pleasure to be joined today by Eri Yoshimura, who is Senior Manager at the NCD Alliance Japan, Christine Hancock, who is a nurse and director of C3 Health, an organization here in the UK. And Christine is a member of the UK Working Group on NCDs. I'd also like to welcome Emma Feeney, who is Director of Global Advocacy and Policy Engagement at the George Institute for Global Health here in the UK. And we have joining us today Kaiser Lindberg, an advocate, member of the Our Views, Our Voices advisory committee, and Kaiser is based in Sweden. Thank you for joining us today, Kaiser. So to kick off our panel, let us start by looking at how NCDs have been included in the COVID response in your country. And we know that we know that disruptions to NCD services and care have been severe during the COVID pandemic. So how do you think governments, how well are they doing with regards to tracking the impact of COVID on care for NCDs? And perhaps we could start with Christine, please.
I don't think they've been doing very well in this country. I think different parts of general practice might be doing quite well, but I think it's very variable. So the UK has a system where, in theory, everybody has a general practitioner and they have their records. They have moved amazingly quickly into virtual consultations. And of course, those work well for some people and with some conditions, but are very challenging for others. We still have in the UK significant number of people who don't have easy access to the internet. People who may in the past have gone to a local library or to a coffee shop, or people who do have internet, but they only have in the family one computer, several members in the family. So the idea that everybody's got excited about that so much can be done online and it's saving people's time, and all of that's good. But one of the areas I think we at C3 have been concerned about and interested in is hypertension. How do you monitor somebody's blood pressure at the moment? And clearly, if they have their own monitoring machine and they know how to use it, then that's great. And they can have a virtual or telephone conversation and change medication. But for a lot of people, that won't be the case. And of course, as we all know, hypertension is very significant in morbidity and mortality linked to COVID. And it's also not diagnosed in many cases. So it's the silent issue. So, and then again, I think there's what I guess many countries are seeing, people not being able to access care and treatment because of so many coronavirus cases, and people being scared too. And we've a lot of anecdotal evidence in this country, and shown overall by the general numbers of falls dropping in people attending emergency departments, then absolute cancelled treatment, and some very worrying statistics from the cancer world, which I think is the most obvious one. The cardiovascular world is often hidden, but some evidence increased deaths at home from apparently non-COVID conditions, suggesting people who haven't sought help. So much of it, there are some figures, but a lot of the detail, I think, is more anecdotal than quantitative. Emma may be better informed than me on some of these, and happy for her to continue the UK tale.
Thank you, Christine, and thank you for highlighting some of those aspects and the digital divide. You know, that is just so important, and other important points. And as you said, a perfect segue over to Emma, please.
Thanks, Christine, and well, both Christines, in fact. Yes. So just to echo actually some of what you were just saying, Christine. I mean, I think in the UK, in fact, the NHS does provide a fair amount of data in terms of what's happening at the service provision level, and particularly, as you say, on high profile areas such as cancer provision. But what we tend to get are these sort of headline figures, mostly focused at sort of national level. And we really need a better understanding of what's happening much more locally, as you say, where it can be quite patchy. So we know that most non-COVID health services were shut down between April and June in order to free up us to respond to the pandemic. And at the same time, fewer patients were seeking care during the lockdowns because, as Christine mentioned, concerns about infection, but also this concern about being a burden on the health system, which is something that does come up a lot. And in fact, there was some research out last month showing that nearly half of the public would either delay seeking medical help or wouldn't seek help at all even if they had a symptom or quite a serious concern. So that's obviously something that we really need to be conscious of. I think we know that because of the shutdowns that we saw between April and June, there are now sort of mounting delays in terms of a backlog of services, and inevitably some are being prioritised over others. And so for me, a big thing that's missing is really understanding what the equity implications of those decisions are, which we're not really getting. So, for example, you know, how are they affecting older people with multiple NCDs or women, or how does poverty play a role, and so on? How are the impacts differing in different areas, and why? Because, as Christine said, this is quite a localised thing here in the UK. And what role are those patient concerns playing in terms of the way different groups, different population subgroups are accessing treatment at the primary or secondary level? And we also need a better understanding of the impact beyond the sort of the high profile cancer. As Christine again has said, you know, we don't hear much about other NCDs beyond cancer in this country. So for me, we have the data, but we need much more analysis of that data in order to understand differential impacts of what's going on, and what the impact of those prioritization decisions will be for different groups. And we really need to take that sort of data analysis and be working with people living with chronic conditions and with the health workforce in order to understand where the most urgent priorities now lie, and making sure that we're really getting the full story in order to make those decisions about where to put resources, which are inevitably tight at the moment. So thank you.
Thank you, Emma, for providing that quite a comprehensive perspective there. Kaiser, I wanted to know, so what, we're kind of talking about, assessing the impact of disruptions to NCD care. What do you think our kind of governments and decision makers should be doing to minimize those disruptions?
Hi, it's obviously a complex question. I think there are some simpler things you could do, such as, at least in Sweden where I'm based, our prescriptions only last a year, for example. So you would have to call in every time to your doctor and take up resources that way to just renew a prescription on something like insulin that I use, that I will be using for the rest of my life. It's a life-sustaining medicine for me, right? I'll be using it for the rest of my life. It's not the biggest thing we can do, but it's simple things like that as well that free up resources. If you know a patient is going to use a medication for a long time, just make the prescription last longer, right? It frees up so much time for everyone, right? I think it's also hugely important. I always talk about psychosocial support with NCDs, but it's so important during these times as well. It is for everyone, of course, but especially I would say people living with NCDs and those who are within the risk groups. Everyone is feeling lonely. Everyone is feeling isolated, and especially those living with NCDs. There are layoffs going on, and there are things affecting people living with NCDs, including access to physical activity, the possibility to move around, a different type of, so to speak, strategy on food, a different access to food, etc. So I think that's a massively important area that we need to focus on. I think it's also, I definitely understand your point, Christine, on digital healthcare not being for everyone, but I do think it's important to realize it has a huge potential for a large part of the population. It's not a one-size-fits-all, but it's a great tool that we can use to, again, free up resources for those who perhaps need them more in person. Anything we can do in general, I think, to help people self-monitor and self-manage, I think even outside of the pandemic is important. Any kind of tools we can give people living with NCD so that they can manage in their everyday life. Living with NCDs, you see your healthcare professionals a couple of hours every year, right? The rest of the time you spend alone. So whether or not we're in a pandemic, it's so important to give these people, to give us the tools that we need to manage ourselves and to monitor ourselves. And I think that it's especially obvious in this situation where we are now. And I think patients have been pushing for this for years. Every other aspect of our life, more or less, is digital. Everything is so simple, right? Why shouldn't it be this simple to take care of your own health? I think I've been seeing it used a lot more now in the pandemic, and I hope it continues. Patients have been very positive about it before, and it's mostly been, I have to say, the healthcare professionals who've sort of been skeptical about it. But I hope this is one of the solutions, one of many. And it's also a major, in terms of psychosocial well-being as well. I used to go to the hospital about once every week previous to the pandemic. I have type 1 diabetes and I've had brain cancer and lots of endocrine diseases. So I was about once a week at the hospital, not including phone appointments, pharmacy, blood work, all of that. And the fact that I now can do this from home is such a relief for me. It's really, it's hard to describe how much it's meant to me to not have to go once a week to the hospital. It may not sound that much, but it adds up. It really does.
Thank you for sharing that, Kaiser. That is really interesting, isn't it? So the you know, opportunities that we are seeing, and your perspective there of how this has actually been helpful. This kind of push into really pushed by need to have to turn some things into that virtual space, but also really noting Christine's points on the digital divide and notions of equity. Eri, could you share with us your perspective from Japan, please?
Okay, thank you, Christina. Hi. So in Japan, I don't think our government do a good job to tracking the cases, in particular for the people living with NCDs. So I think situation is pretty much similar to the situation in Europe. And I also want to talk about the digital health in this section as well. From early phase of the pandemic, our Prime Minister, local governors, Minister of Health and Labor and Welfare continue advocating that COVID-19 particularly affects those who have chronic conditions, people living with NCDs, and the elderly people. In the region of Asia, particularly Taiwan, has been successful control COVID-19 very well, because they had a lot of lesson learned from the previous pandemic of SARS, and they had a strict policy to control from the early stage. And they applied technology effectively to follow up cases. And also Taiwan's president's great leadership for evidence-based policy was showing her empathy toward people was highly evaluated. And on the other hand, I think it has been controversial if Japanese top leadership was successful or not. However, in the context of NCD services, it was quite epoch-making that Japanese government deregulated telemedicine in April. So in 2018, our UHC system insurance started to cover telemedicine, but it was applied for the limited diseases, for example, mental health or hay fever were opted out. And telemedicine was not admitted for the first visit examination, but was admitted for people living with NCDs who have visited the healthcare facilities to see their doctors before. But this April, due to COVID-19, the government deregulated telemedicine policies as temporary measure. And the current Prime Minister tried to make this measure to be permanent measure now. But payment of medical fees for healthcare professionals on telemedicine is still less than payment when patients and doctors see in person. So actually, it does not motivate healthcare professionals to apply more telemedicine. For now, telemedicine makes up only 15% of all medical services. So I think this is kind of a window of opportunity to provide more telemedicine for people living with NCDs who are at high risk of COVID-19. But still, I believe this policy change made by our government in April helps people living with NCDs in terms of providing more opportunities to get diagnosed, treated, and prescribed at home.
Thank you, Eri, and how interesting to hear of examples of what has been done in other countries. And thank you for sharing the Taiwan experience. And I know that part of our panel in a moment we're going to be discussing looking ahead and how can we learn from this experience for future pandemics. So it's interesting for you to share the Taiwan case study there and how they've been kind of quick off the marks based on their experience of a previous pandemic. Emma, I wanted to ask you, I know that you shared already some good recommendations there for governments in assessing disruptions, need for local data and so on. Is there anything else you would like to add on this topic?
Thanks, Christina. Well, yeah, perhaps just to pick up on the telehealth point, actually. I mean, I think all around the world we've seen that this has really taken off. There's been a huge rise and there's been, a bit of a telehealth revolution everywhere. And it's really good to hear such positive things from Kasia and also from Eri. I mean, I would say that, as with many things in this pandemic, it's all been happening extremely quickly. And I do perhaps just to echo sort of some of the points made at the beginning, I think we do need a better understanding of how it's working, just to ensure that proper guidelines and systems are in place, if, as many countries will do, I think in line with what it sounds as though the Japanese government is looking to make it permanent. I think other governments will be doing the same. But I think if it is going to be the new normal, then I think we really do need a strong impact of a strong understanding of what the impacts are, again, for different population groups, but also, you know, what are the impacts on GPs themselves and the kind of services that they provide. And so I think we have got a real opportunity here. And if we actually put some resources and invest in integrating research programs with these new measures being rolled out, which can evaluate how well they're performing, what the sort of different differential impacts they're having, and so on, then we can use this opportunity to get insights into how we can develop better approaches to NCD care well beyond the pandemic. And so for me, I think the key bit of this question around, you know, what measures should governments be doing to reduce disruptions and to measure their effectiveness, I think the second part of that question is really key for me, the bit about what's being done to assess the effectiveness of these interventions and who are they effective for. So, I mean, interestingly, I'm not sure that there's enough focus on this generally at the moment. And the George Institute actually conducted an analysis of all the COVID-19 related interventional clinical trials that have been registered globally. And what we found was that actually only 5% of all trials focused on NCD control in the context of the pandemic. So really hardly any. And of those that did, only actually 3% focused on cardiovascular disease, only 4% looked at endocrine, nutritional, metabolic diseases. So, you know, almost all of them were focused on mental health conditions. And I think we really need to be looking at a broader range of interventions on a broader range of conditions in order to sort of understand how we can mitigate the impacts of COVID-19 on NCD care, both for the current pandemic, but also going forward.
Thank you, and it's great to have this, you know, kind of academic research perspective coming from you on our panel today. And as you say, you know, there's an opportunity for doing this type of research, and an imperative really to be doing this type of research now. But I really get your point of just the time pressures of collecting this data and analyzing it in the rigor that it requires. If we could shift gears for a second and look at, we were talking about, you know, what we would like to see our governments and decision makers do. Of course, civil society, healthcare professionals, people living with NCDs are also playing a really important part in the NCD response, and of course as part of that broader COVID response. Well, on the subject of the health workforce, before the pandemic, the NCD Alliance had put out a report, Protecting Populations, Preserving Futures, that shares recommendations on enabling an optimized health workforce in the NCD space. So obviously that includes things like, you know, political leadership on NCD care, resourcing for strengthening the health workforce, and so on. So I was kind of curious to get some of your thoughts on how can civil society be leveraged basically in this context, and what are you observing in that regard with so how are you seeing that engagement? And if we could start perhaps first with Kaiser, who has of course an advocate with direct lived experience.
Thank you, Christina. I think it's been interesting to note in a setting like Sweden and a lot of other high-income countries, NCDs is not really a concept that we use. It's not very well known because it's not in opposition to anything. We mostly have NCDs. That's what people deal with on a regular basis, right? It's not, as a concept as such, it's not very well known. But I think that what I'm observing, I think campaigns, in all honor, campaigns are great and initiatives are great, but what I'm observing and I hope will will sustain is a deeper understanding from the general public about what it means to live with an NCD, with a chronic condition, or be in a risk group. I really, really hope that that's something that will stick in people's minds, because hopefully this is something that will fundamentally sort of change their view of what it means. I think people are seeing actually how vulnerable a lot of people can be. This is such an obvious situation, situation. I think what's interesting as well is the parallels between how people are sharing their, and rightfully so, sharing their complications of having lived with COVID, their long-term complications, and sort of the parallel that goes with living with NCDs, right? Hopefully it gives also a deeper understanding of what it means to live with a chronic condition. It's also interesting, I mean, there's obviously a lot going on with the pandemic and what we need to do to protect ourselves and our families. And what's interesting is that a lot of people living with NCDs are always risk groups. I'm a risk group for a regular seasonal flu, right? And people still send their kids to daycare because they think, well, you know, he hasn't had a fever for 12 hours. That's fine. You know, it should be fine. But that's always a risk. That's a risk for me every year, right? So I'm hoping that long-term this will have changed the general public's perspective of what it means to be a risk group, so to speak, or to live with a chronic condition or an NCD. Call me naive, but what I have loved to observe during this time is an increased sort of that people are increasingly helping others. You know, they're helping their elderly relatives or their neighbors who are in risk group to pick up their medicines or shop for food. Grocery stores are opening earlier so that people in a risk group can go and shop. Then that's disputed. It's not only positive, but I've loved to see this. And call me naive, but I hope that it sticks around. I hope that fundamentally there's an understanding of what it means to live with a chronic condition.
Thank you for sharing that, Kari. So that kind of that community spirit, if you will, and these kind of community support structures, and obviously civil society is so key in enabling that, and it's great to have that kind of firsthand experience shared here. And I'm sure that this is something that kind of feeds in not just the community, but also, you know, all the way to the top with governments when they're kind of making decisions as well. Thank you. Eri, would you like to share your perspectives on this theme, please?
Christina, I really like the idea that Kaiser shared, that community, it's a kind of opportunity for community to understand each other. I would like to share some leaderships that I observed in Japan. So the Japan Medical Association, which is a kind of group of medical doctors, showed great leadership of the pandemic. They set the task force team with the experts for COVID-19, and then they kept raising an alert that we were close to the medical collapse. In the context of NCDs, they actually kept saying that we need to have family doctors, even before COVID-19. But in this particular situation, on the pandemic, they're emphasizing the significance to have the primary doctors to detect COVID-19 and other NCDs diseases early. And additionally, many societies and colleges of diseases such as Japan Society for Dementia Research, Japan Cancer Society, and the Japan Diabetes Society advocated people living with NCDs and the healthcare professionals that we should not hold back, wait to see doctors, because medical checkup, early detection, and interventions to NCDs are quite important. So some of them released the quantitative data. For example, due to the survey conducted by the Japan Society for Dementia Research, I guess it was happened in May. So 82% of people living with dementia visit medical facilities less frequently than before under this pandemic. And then in Japan, we had less death cases due to COVID-19 at the care facilities for the elderly people than other countries. Those who live in or visit care facilities frequently have multiple NCDs, and they have a higher risk of COVID-19. In Japan, why we are doing a good job at the care facilities, because I think first their basic preparedness for infectious diseases such as hand hygiene, wearing masks, and sterilization were effective. And the second, our care facilities are often smaller than those in the US or Europe. So these are the kind of the successful phenomenon under this pandemic. And then, unfortunately, I don't see many leaders of people living with NCDs participate COVID-19 response meeting hosted by government. So I think more voices for people living with NCDs will be needed in Japan at the government level. I think this is kind of the next challenge for our country. This is for me.
Thank you for sharing that, Eri, and how interesting. Obviously, this is something that is common to high-income countries, but particularly the case of Japan with such an with basically an elderly population and these kind of inverted triangles, population pyramids, and obviously how you're dealing with the context of COVID in care settings. Thank you for sharing that. But this important point of social participation, involvement of people living with NCDs in decision making there. Thank you for raising that. And Christine, over to you. You have obviously civil society experience. You also have that healthcare professional experience. Could you please share with us your thoughts?
Yeah, thank you. I think, like lots of people, the pandemic, certainly in Europe and North America, the pandemic was a complete shock. I know there are wonderful gurus who've been seeing that it was coming, but that didn't include me. And there was a sort of feeling of this wave that was just coming, unstoppable. And for a moment, I think it took almost collectively everybody's breath away. And actually, that continued for some while. So nobody seemed able to think past the pandemic. And I think that with reflection on the early stages of the pandemic in Europe, there needs to be some real critique of what happened for various people with NCDs. And I think some of that will be very uncomfortable. And I think it will be demonstrated most around cancer, but also cardiovascular catastrophes, heart attacks, strokes. So the evidence is a little bit of quantitative evidence in the UK, but much more, I think, anecdotal evidence and not good enough reflection in a scientific way. And I think that one of my colleagues, one of my neighbours, who's an emergency room physician, was really critical of the oncologists, the cancer doctors in her hospital, because after the first few months, people with serious complications of cancer, either treatment not carried out or undiagnosed, and she said, what were the oncologists doing? Now, I know what the answer was for many places. They were being rapidly trained to deal with COVID. And there was a sense that it was the only problem. And that's understandable. It's easy, 6 months on, when there's some evidence that the pandemic's not quite as devastating. People have learnt more also about how to manage and how to treat it. And there really does need to be, I think, a real critical analysis of what happened to people and how can it be done differently. We can't be perfect, and certainly in a really sort of selfish way. I remember thinking early on, C3 Collaborating for Health, which is about preventing NCDs, we might as well pack up and go home. Nobody will be interested. And then relatively quickly, I realised that actually that's what it's all about. And I think that understanding is still not very close away from the, if you like, the professional world, including civil society, who are understanding it. And in an ironic and almost unkind way, there's some advantage in having highlighted obesity, hypertension, conditions that could be better prevented and managed in the context, if the world is going to listen because of COVID, well, then I think we in civil society need to get in there, make sure those lessons do get listened to and learned. Because if you like, it's an ironic and rather cruel opportunity to get an agenda that's been very difficult to promote and have people listen to, get it listened to much more. I think there are statistics everywhere, but I think 40% of people who died of COVID in Italy had hypertension, and I think a similar number with diabetes, type 2 diabetes. I first learned about the obesity issue in the ordinary national press in France, where doctors were picking it up almost anecdotally. I think there are issues there that help inform all of us, but also hopefully help us inform a wider audience.
Thank you, Christine, and you're absolutely right. NCDs being in the eye of the storm, and almost this notion of the sendemic, right? These kind of colliding pandemics, COVID-19, with obviously the burden of NCDs and all the underlying determinants of health, and it's definitely a challenge for civil society to be making sure that this is considered in preparedness efforts. Thank you for highlighting this. So let's look ahead. How do we? You mentioned an ironic and cruel opportunity, Christine, and that's a good way of putting this. How do we learn from this experience to ensure recovery and resilience looking forward? Eri, would you like to share some thoughts, please?
Sure. So the strengthening health system. So this is an opportunity to strengthen the health system, and the UHC is essential. And in our country, probably a better healthcare services for migrants is also a key in the future. And I think it is also quite significant to have more interfaces, touch points between healthcare professionals and the people living with NCDs. So due to the security restrictions in Japan, applying the IoT system to medical services is not common yet. If we have more options to communicate between people living with NCDs and healthcare professionals, for example, like people living with NCDs input their blood pressure on their smartphone every day, and their information transfers to doctors, so the doctors can detect their physical changes early to intervene. Even people living with NCD, although they do not need to visit, they think they do not need to visit doctors. So this is also challenging for people living with NCDs, especially the elderly people, to use technologies, as some of you mentioned. But so devices, user-friendly devices would be expected to help in the future, probably, for the better preparedness.
Thank you, Eri. And Emma, perhaps over to you. Looking ahead, please.
Yes, just to pick up perhaps on the what you described so well, Christina, as an ironic and cruel opportunity, but clearly there is an opportunity here. There is momentum around NCDs, which are now clearly seen as a risk factor for COVID-19 outcomes, and I think that's an opportunity at a number of levels. So, for example, at the policy level, we're seeing that policymakers themselves, having first-hand experience, can be a real mover of the needle. Here in the UK, our Prime Minister Boris Johnson, who is overweight himself and suffered complications of COVID-19, he has now launched a new government plan to tackle obesity. And so it would be great to see that developed along with the health workforce, along with people living with obesity, and along with academic experts as well, some of whom are doing some really exciting research in this area into people's lived experiences of food environments in order to really better understand how we can support people to eat well. And it's not just in the UK. So Australia is now also planning to launch an obesity strategy early next year. I think there are also opportunities with the public. So, for example, we know from some research we did in both the UK and Australia that people who smoke are, very conscious now of the risks. They want more information from their GPs about the COVID-related risks they face. But the coronavirus also seems to be increasing the receptiveness of smokers to quitting. And I think this is something that we should also be trying to take advantage of by making sure that the GPs, the health workforce, is equipped to provide the kind of support that people want based on their preferences that will really help them to quit. And perhaps another example of that is ensuring secondary prevention measures are in place for people with cardiovascular disease. This is a really key thing that it should be straightforward to do, and it would really fall in with that push towards emergency preparedness, resilience building, and so on. So I think there is a real opportunity there. I think, as the representative of the academic sector, you'd expect me to say, I think we also need to be sort of cognizant of the fact that just when we really need research into effective NCD care the most, funding for this research is being squeezed actually from all sides. So a lot of big funders are moving their funding from NCD research into the research of the coronavirus itself, totally understandably. At the same time, medical research charities have taken a big hit in terms of their donations. They've had to close their charity shops. All of the fundraising activities have been suspended and so on. So we're going to have a big shortfall, certainly here in the UK, a huge shortfall into what could be potentially life-saving research. And I think, we really need to prioritise learning from this pandemic in terms of what does work to maintain NCD care and what doesn't, in order to think about how we manage this better during future pandemics, but also just how, as we keep talking about building back better for a new normal. And I think we do have an opportunity now to reset the way we provide care and ensure that it is more patient-led, better integrated, and so on. So I think we really do need to sort of make the most of this cruel opportunity, as you described it. Thank you.
Thank you, Emma. And Christine, perhaps over to you if you'd like to build on some of those remarks.
Certainly, thank you. And I think in a way, this question of building back better is so crucial. And there are horrendous things that many of us knew about, but are becoming much more obvious and perhaps better known. And I would say in the UK, 3 really big areas that we need not to forget. One is inequalities. The NCD world in more industrial nations has always known that NCDs are a matter of inequality and poverty, and that's been made very obvious. I think the position of people from an ethnic minority heritage has always also been known, but some of the most recent information is really stark and shocking. That Black people have twice the risk of actually contracting COVID-19, and I don't think we know why that is, but that is really shocking. And the third thing, an area linked to my past and background, is the very welcome focus on the workforce. And that's not unrelated to the inequalities and the minorities. Something like 64 Asian physicians died of COVID-19 in the early days of the pandemic. It's very significant. I think 1,200 nurses worldwide have died as a result of the pandemic. And the focus on people doing jobs that are risky and poorly paid is something that I hope won't get forgotten. And it doesn't just include nurses and doctors, it also includes people cleaning the street, people working in shops, people working on transport. So in many of the cities in the UK, people understandably have been very nervous about using public transport. But that's for those of us who can work at home or who have cars, and that's not for everybody. And so I think in London, something, I think 16 bus drivers died in the early days of the pandemic. So this question of inequalities, people from a minority background, and the workforce on whom we're most dependent, who are so poorly paid often, and care homes in all our countries, and certainly in Europe, have been another area where all those issues have been exposed, and exposed not something about the pandemic, but about the weaknesses in our society, more than just the health system. Thanks.
Thank you, Christine. And that is, well, I wanted to thank you all for this very rich discussion and kind of hearing from experiences in different parts of the world, and just the different perspectives that each one of you brought to these discussions. If I may just pull on some points made here to finalize, perhaps to start with Christine's note here, that this pandemic has obviously had is having profound human and social impact, and we've heard from Kaiser, and that perhaps now people are understanding the risk that people living with NCDs are under, but just this impact that it's had on individuals' lives lost, and the healthcare workforce, and many others. I think we've heard some really strong points there about the need for research and data, and Emma was saying, isn't this ironic that now when we need this research more than ever, there are matters of resources there that need to be discussed, and financing, of course, but this need for research and data so that we can learn from what is happening, what is working, for future pandemics, and minimizing disruptions to NCD care. So really this need on, to look at the different interventions being applied, and to learn from them. We heard about the role of communities, people living with NCDs, obviously central to this, and social inequalities being so linked to the COVID pandemic, and of course at the heart of the NCD pandemic as well. And as we shifted to discuss policies and this kind of systems level thinking, some interesting points from Christine with regards to in-depth reviews of what is happening, a role for accountability, really understanding the impact of disruptions. And Emma had noted, we're hearing examples coming now from the cancer space, but much is needed to understand impact on all the different NCDs and disruptions to care, and the impact. We heard about opportunities with the use of technology, self-management opportunities, but also some attention that we need to provide from an equity perspective, and the digital divide. I think we heard quite a lot around, the opportunities for health systems strengthening universal health coverage, and finally the point that Emma was raising, and I think all of you raised, with the kind of windows of opportunity here for prevention of NCDs, and obviously there is more initiative from the public, and perhaps appetite, but this is a time for us to be pushing our decision makers to be doing more to ensure healthy environments and healthy populations. Thank you all for your fantastic insights, and I hope for those of you listening to this panel that you have found that equally interesting. Thank you for joining us today.